Good morning from Dhaka. I am Dr. Noor Alam here in the BSCI Fellows course.
And I am Dr. Vijay Dotto.
May I first introduce my co-moderator, Dr. Vijay Dotto.
Very good morning to all.
Dear fellows, I think you all joined already. This program is designed for our promising interventional cardiologist. We are in the pandemic. We are trying to structure this program for their easy understanding. And first of all, I would like to introduce our chairpersons of this course, Professor A.K.M. Fazlur Rahman, Professor Mir Jamaluddin, Professor Syed Ali Hassan, Professor Colonel Dr. Syed Alia Sultana, Professor Muhammad Mahbubur Rahman, Professor Syed Nasiruddin, Professor Dipankar Chandra Nag, and Professor M. Saiful Bari. So, dear fellows, this is one thing to be noted from your side. You must ask your question, put your question in the chat box. After presentation, we will discuss. Our time is time constraint. Nevertheless, we will try to address your question. Our renowned faculties will answer your question. So without further delay, we want to proceed our session. First of all, I would like to invite Dr. Ramesh Duggabati from USA. He is the chair of International Sky Committee. Dr. Ramesh, can you hear me?
Yes. I can hear you quite well. Thank you very much for having me. And I want to congratulate each and every member at BSCI for this wonderful meeting that you have arranged today.
Thank you, Dr. Ramesh. Dr. Ramesh will give talk on Cath lab basics and overview. Again, reminder for the fellows, please put your questions in the chat box. After the presentation, after the lecture, we will try to answer. And for our distinguished lecturers, please try to finish your lecture within your allocated time. Thank you, Dr. Ramesh.
So thank you very much. It's great pleasure to have all of you. I'll share my screen today and now. Sorry for, can you see my slides?
Yes. Go into PowerPoint mode.
Okay, so I want to thank Dr. Kalam, Dr. Rahman, and everyone to having a wonderful program and agenda that we have come up with. And I want to thank each and every fellow who has joined today. And I'm just going to touch a basic views of Cath lab. And it's just as an overview. And of course, everything is going to be dealt in greater detail as we go through this program over the next 3 days. Number one, I think it's all about the teamwork. The fellows have to realize their role. And as physicians, we should have proper credentialing to do the procedures in the Cath lab. You also need to have people who are certified, such as the nurses and technologists in your Cath lab. And everything that we do in the Cath lab should be outcome focused. So whether we want to do an acute MI versus actually even use some device that actually has come out into the market recently, we need to focus on how to improve the outcomes for these patients that we take care of. And that depends upon how successful you could be using that particular device or not. And other most important thing is learn from our complications. I think you should not shy away from having a complication. We will all have complications. And if someone says that they do not have any complications, I feel that they have not done enough number of procedures. So when we do, we will have complications. And when from complications, we have to learn from them and make sure that we cannot repeat the same complication again in the future.
International committee member.
So the checklist for these in the Cath lab when we take a patient is what is the procedure type, what is the indication, and whether you have a proper history and physical, and affirm that the patient is NPO, and also use ASA, that is American Society of Anesthesiologists, and Mallampati score. So the more comorbidities that the patient has, the patient will be considered as the more complex the patient would be. And by opening up the patient's mouth and looking at the ability to look at the posterior pharynx will actually tell us whether Mallampati score is 1 to 4. And if you can see the back, obviously it is 1. If you cannot see it, that means he's going to be having some difficulty in airway during the procedure if you do too much sedation, or just maybe lying down flat also can cause some airway obstruction. Confirm the allergies and compliance to medications. Most of the time, actually, we forget to know what procedure the patient has come for, whether it is a purely PCI or is it a left heart cath, and do we need to do an LV gram in each and every patient? By using more contrast in an LV gram, we are going to affect the patient's kidneys. So therefore, my recommendation, and we do not actually have done in our center any LV gram since 2013, unless we suspect some VSD or actually there is a Takotsubo type of picture. Only for certain particular indications we use LV gram now. But hemodynamics are important. Every patient should undergo hemodynamic assessment in the cath lab before we start actually injecting the coronaries. By knowing the left ventricular end diastolic pressure, we can guide ourselves how much contrast can we use, how much hydration should we be giving these patients, and what should our approach be in a patient with a LVEDP of 40 versus 14. You know, there is obviously you need to think about airway protection in somebody who has a LVEDP of 40. We need to think about maybe trying to use diuretics or balloon pump. So there is all these checklists should be coming into your mind as we go further. The most important part of actually coming and bringing a patient in the cath lab is whether we have taken an informed consent. In the United States, most of the problems that come up with lawsuits are because of improper obtaining of an informed consent. What does an informed consent mean? It means that there is a process of communication between a patient and a physician. I'm sure in India and Bangladesh, it is not just the patient, patient's family also has to be included. And that results in a patient's authorization or agreement to undergo a specific medical intervention. I always feel that every attempt should be made talking to the patient as well as to the family. Because if in my own personal experience, I tell you that one of my patients died on the table during an acute MI, I felt very bad that I did not communicate with the family before taking the patient in. And now I make sure that every attempt that I can make with the patient's permission to talk to the family as well. So explaining to the patient in layman's terms is very difficult, especially the more advanced we become in our training. We start using more medical language and trying to forget how a lay person will understand. So this slide actually shows that how confused the patient could be after explaining them. Try to simplify and make them understand in layman's terms, and that is what actually all the informed consent is about. When we talk about how PCI is perceived, this is a study that was done by Harlan Krumholtz at Yale, and what are the perceptions of benefit and risk of patients undergoing first-time elective PCI? 75% of the patients believed PCI would prevent future myocardial infarction. 71% believed PCI would prolong their life. Only 46% could recall at least one possible complication. We know that this is not true. You know, we cannot prevent future myocardial infarctions. We cannot prolong life. So probably we are not explaining in the United States properly to the patients, and when we obtain a consent. The majority of patients had unrealistic expectations about the long-term benefits of elective PCI and was not aware of the potential risks. So that is unfortunate that this is not a proper informed consent. So then once you have an informed consent, we need to talk about how to do a coronary angiogram. Unless you do a proper coronary angiogram, you cannot do a PCI. You need to see the lesion properly. Historically, the first coronary catheter was the Sohn's catheter. It was a tapered tip with the end hole and 4 side holes near the tip. And the catheter was always pushed against the aortic valve and or the aortic wall to deform the tip, and was then torqued to position the tip in the coronary ostium. Initially, this actually catheter was used to inject, do an aortogram and inject contrast through all these holes, and 4 side holes help to get a good picture. And one time accidentally, Sohn's injected the right coronary artery, and as many of you know, patient went into VFib arrest, and he had to be, he didn't know what to say. He just said cough, and the patient survived. So then afterwards, Judkins from Loma Linda in California, he developed catheters, and Judkins and Sohn's together, they're the founding fathers of SCAI. And subsequently, the Schoonmaker King, which is a multi-purpose catheter, was released along with the Amplatz catheters into the market. So this is Mason Sohn's. Always remember our historical figures, and the founding father of SCAI. And he actually was performing a coronary angiogram on 11-inch image intensifier. And he did the first coronary injection by accident, as I mentioned. And if you see, the arrow is marking actually where the film is being collected. And the patient has not, is in a cradle, and rather than the II moving, actually the patient's cradle would be moved. So in those days, that's how it was done. Now we have much more sophisticated equipment, and one should understand in the cath lab how to function this particular equipment that you're used to, or you're going to be using every day. So you should become a leader in understanding not just the technologists in the cath lab. You should know each and every part of that equipment in your cath lab and how you can fix it. This is Mel Judkins, and as we mentioned, he is the one who we commonly use all the catheters that are invented even today, where Judkins left, Judkins right, and the pigtail catheters, as you can see in these pictures. What are the routine angiographic views? And in the left, I always start with the LAO cranial, and there are 2 views. If somebody asks you, you need to get is LAO cranial and the RAO caudal. These are called the surgeon's views. Based on these 2 views, the surgeons can decide whether what part of vessel should be grafted or not. So, but ideally, you should go to LAO cranial, LAO caudal, RAO cranial, and even AP cranial for the left coronary. And the right coronary could be LAO cranial and or RAO, and or LAO caudal to sometimes look at the ostium of the right coronary artery. My go-to, as I mentioned, I start off with LAO cranial for the left, go to RAO cranial, RAO caudal, and end with a spider view or LAO caudal. I use this technique so that actually the II remains on the left side in LAO for shooting the right coronary next, which is also the first picture I take is LAO cranial. So refinement of degree of whatever angles you want to do and how steep you want to put in oblique views, right anterior oblique or left anterior oblique, and cranial, and how much cranial or caudal you want to do depends upon the patient's size as well as the complete vessel visualization. The steep angles that you use, the radiation is much higher. In obese people, you may not be able to get good pictures in steeper angles. So you might want to avoid that. The other most important thing is whether it is coaxial or non-coaxial. Here you can see it is non-coaxial in the right coronary artery. It is almost like a cusp injection that is not really good. And whereas in the coaxial one, actually, you can see that very nice left coronary artery injection, and you can see the significant disease in the mid left anterior descending artery. So suboptimal opacification of the circumflex artery, here you can see that it's actually well seated in the LAD. Of course, there is a proximal to mid LAD lesion right at the septal perforator, and however, the circumflex is not very well visualized. What should one do at this point of time? If you do just a simple counterclock rotation of your catheter, whether it is a JL 3.5 and from radial or JL4 from femoral, you can easily get much more opacification of the left coronary artery as left circumflex artery, as you can see here. So what happens after the coronary angiogram? You need to follow the patient up in 2 to 4 weeks. You need to make sure you check for creatinine, and depending upon the length of the duration of procedure, check for radiation burns, check the site of catheter insertion and or sheath insertion, and compliance to medications and lifestyle modifications, and especially cardiac rehab in people who had probably acute coronary syndromes. Radiation is almost, I don't think you'll have a lecture from in this entire 3 days, I think, on radiation injuries. So that's why I want to include few slides in this basic overview of cath lab. There are two types of radiation injuries that happen: deterministic effects, which are dose dependent, the amount of radiation that you give, so such as skin erythema, desquamation of the skin, bone marrow suppression can happen. People can develop cataracts, sterility, and fibrosis. In people who are operators, we can actually have problems with the sterility, with also with losing pregnant operators can lose babies, have stillbirth, and actually men, many of them who have worked for several years, or the women as well, have developed temporal, glioblastomas, mostly on the left side, neurological tumors. And the stochastic effects, there's no relationship with the dose, no threshold. Cancers can happen in these people. So quickly, I'll go over the two months and 6 months. And if after 2 years, sometimes radiation injuries can initially improve for a little bit and come back after a little bit later. The main way to limit the radiation is observe the amount of dose that the patient is getting and change the angles. Do not work in the same RAO caudal or LAO cranial view, but keep changing, maybe even just 1 to 2 degrees. If you change, I think you'll be amount of radiation. And you can see alopecia here, and patients also undergo neurointerventional procedures for acute stroke. The fluoro time was more than 70 minutes, and they presented with the hair loss here, as you can see. So the inverse square law is very important. The amount of radiation exposure to the faculty or to the fellows is, you just have to depend upon how far you are staying away from the patient's table. And so if you're take 1 foot back, you probably will get 1/4 of the radiation than actually where you are standing in the 1 foot closer to the patient. So it is all related to the time, distance, and shielding. So distance is something that we can always pay attention to. So utilize radiation only when imaging is necessary to support clinical care. Minimize using cine. You can always use fluoro-safe function on the new machines, and minimize use of steep angles of X-ray beam. Minimize use of magnification modes, and frame rate and fluoroscopic and cine frame rates could also be reduced. Keep the image receptor close to the patient, and utilize collimation to the fullest extent possible. And monitor radiation dose in real time, wear your badges properly to assess the risk for yourself and also to the patient that you would be giving. So post-procedural issues, as we mentioned, the amount of radiation, 5 to 10 gray, you should definitely call a patient with an office visit within 30 days. And more than 10 gray, an office visit within 4 weeks is recommended. More than 15 gray, hospital risk management should be contacted within 24 hours. Ideally, it should be less than 5 gray, even if it is a CTO. And I'm sure Sanjog and others will touch base on how much radiation or contrast use that can happen in chronic total occlusion PCI. Adverse tissue effects is best assessed by history and physical exam, and make sure you strip the patient and examine properly. Of course, if it's a woman patient, make sure there's somebody else like a woman nurse in the room along with you. Biopsies only for uncertain diagnosis. Wound from the biopsy may result in a secondary injury, so try to avoid biopsy as much as possible. So lastly, we'll be talking a lot about all these devices, so that I just made only one slide on these. IVUS and OCT, we have to be educating our fellows as much as possible during their fellowship. to interpret these images and to encourage them to use IVUS and OCT in the cath lab to assess the lesion significance and also assess the stent deployment, and stent failures have to be mandated by using OCT and IVUS. We also need to use imaging mostly in left main and complex PCI. We encourage our fellows to use now almost about 80% of our PCIs are performed with imaging so that they can get used to it. Maybe they don't have to use it after getting 15 or 20 years of experience, but in the beginning, we always encourage our fellows to understand the utility of IVUS and OCT and also how to interpret the imaging pictures. FFR or even before FFR, the patient should not come into the cath lab unless he had a stress test that showed significant ischemia, as well as he is on optimal medical therapy. Only after failure of optimal medical therapy that any person should be brought to the cath lab, and unless they have unstable angina or acute coronary syndromes, obviously. So FFR in stable ischemic heart disease should be done to determine the significance of lesions. And also you will learn a lot about atherectomy devices and other types of balloons that we have available now in Bangladesh. So I think that I will leave it to my other colleagues to talk about that. So in summary, this is mainly about coronary angiogram, and become familiar with one catheter system and make it your workhorse. I'm not here to sell one or the other. Do whatever works for you, whether it is JL 3.5 or EBU 3.5 or 3.0. Use your type of catheters that you want to use. Develop finesse with positioning to achieve coaxial catheter placement. Without coaxial placement, you can actually damage the left main artery or even cause dissection of the right coronary artery that can extend into the aortic root. So please be careful. This not only improves opacification, but also improves support for device placement as well as reduce your complications. Inject adequate volume of contrast. So for the left coronary, you need to use 7 cc injections, and for the right coronary, you need to use 4 cc injections to get adequate opacification of the coronary arteries. And lastly, modify X-ray positions to be certain of clearly seeing the entire vessel and branch origins. I think with that, I'll stop here and I'll be more than happy to take any questions. And as I mentioned, that this is only an overview.
Thank you, Ramesh, for your brilliant presentation. At present, we are not able to see any question. If any question come, you stay. We will then ask to you if any question come. Before going to next presentation, we have an announcement from our scientific secretary. Would you please?
Thank you, Ramesh. Am I audible to you all?
Yes.
Okay, fine, fantastic. Now, I just give you a declaration for our wonderful fellows. Today's event and tomorrow's event, we have a quiz session, and this quiz session is conducted by Dr. Noor Alam. He will give you 3 questions. The person who can answer very quickly and correctly, he will get a wonderful prize from BSI, one of the Society of Cardiovascular Intervention. This is the last time at 12 o'clock. This question is served to you in chat box, and this result should be announced within 3 minutes. So be ready, everyone. And the participant, everyone can participate in this program. The person who answer first, he will get the prize. Thank you all. Now I'm requesting Dr. Vijay Dutta to continue the session, please.
Thank you, Dr. M.J. Ajum sir, for your declaration.